Thank you very much. It's a pleasure and an honor to be up here, actually in Canada for the second time. I had the privilege of working at the Toronto meeting. I appreciate Maureen and Jim making this trip available. It's a very exciting meeting. I think it's probably one of the most informative meetings that I've been privileged to be a part of. And we've heard a lot of things this morning, very excellent pathology discussions and Dr. Ezzet's overview. And what I did as a courtesy, I hope, is to provide you with a handout. I hope you all have it. And the flow of my talk will run just like the slides in order. And I'll be able to brushstroke a few just to reinforce. As Dr. Asa said, repetitio est mater studendum. Repetition is the mother of learning, and I'm certainly doing that myself today. But we'll have the advantage of going now, as Dr. Ezet said, taking it at 7 or 8 months of gestation, because my clinic that started about 15 years ago is a multidisciplinary clinic. My abstract just about summarizes the way we do business, including my schema, and it's not a unique schema. When you think about it in terms of your own experiences, you've probably seen all of the options that I've shown you. But now we're going to look at things in terms of, yes, we have it after the fact, and now we're going to look at the treatment options. I will tell you as an endocrinologist as well as Dr. Ezet that I view neuroendocrine tumors not like the medical oncologists say really as cancer in slow motion. I view it like I view the social disease in my family, which is diabetes mellitus, as the diabetes of cancer. And as such, I consider that to mean that it's a chronic entity, that we keep exercising the best options, and we enjoy quality of life that is no different than if we didn't have it. And so that's kind of been our view. 80% of all my 1,000 patients come from medical oncologists. So you know immediately where that puts them. I think over time that's going to shift. As the anti-angiogenics come into play, I really think the medical oncologist will assume the role again of a non-chemotherapeutic anti-angiogenic armamentarium for treatment. So we'll just go forward, and I'll do as I'm supposed to do. Again, I'm going to brushstroke some of the slides, and so the front part will move until we get to the schema. And so I just ask you to stay tuned to the slides and jot down any thoughts that you might have along the way. This is the slide that I started a long time ago, but it's the evolution of gut endocrine medical therapy. And in fact, it all began in 1902 with Starlitz and Bailey, pardon me, Baylis, not Starlitz. I'll catch it in a moment. It all began in 1902 with the brother-in-laws, and I'll show you their picture in a moment. And then the evolution of the intestinal hormones progressed to the clinical observation of gastrinoma that you heard about earlier, and that was by Zollinger and Ellison, and they described the first tumor that was making excess gastrin and acting as a pathohumoral substance at that time. And then the very big discovery of somatostatin from the hypothalamic area in 1973 started in motion the synthesis of a congener, Octreotide acetate, which then led to the labeling of it, and we'll hear more about that, namely the indium 111, the Octreoscan that all of you have had, or many of you have had, and now the very dramatic development of peptide targeted to membrane receptors in the form of Octreotide labeled with the yttrium-90, lutetium, indium-111 for treatment. There it is, Bayliss and Starling. Sorry, I have a little dyslexia myself today. But that's where it all began. And then I put this slide for Canada because actually it was the medical student Charlie Best and Banting working together in stabilizing insulin in 1921 that led to the development of insulin as a hormone replacement for insulin-dependent diabetes mellitus at the University of Toronto. And Oberndorfer was mentioned earlier. He coined the term carcinoida, which means cancer-like, in 1907, just celebrated the 100 years recently of the coining of the term carcinoid. And then this was an important person, Dr. Ferreter, Professor Ferreter from Austria, and he identified the cell that we're all familiar with and which we heard about very eloquently from Dr. Asa this morning. And that's the neuroendocrine cell. This happens to be stained with neuron-specific enolase, one of the stains routinely used. We use more chromogranin A and synaptophysin, and not so much neuron-specific enolase, but that clearly is the cell. I added the locks to it. I added the receptors to it. And what we are hearing about are the specific receptors on these cells that are under the control of our own somatostatin in the body, and now octreotide and somatulin or lanreotide, which lock into that natural somatostatin receptor, receptor 2, and when it locks in, it exerts an action. In this case, it's anti-proliferative, anti-secretory in the cell. And that's the very basic mechanism from which we all utilize this commonality, as Dr. Asa pointed up this morning. And these are the neuroendocrine tumors, or mimetics of these tumors, that are associated with the neuroendocrine cells. And as we heard, rare, and these are considered an orphan cancer, unfortunately, by definition, under 200,000 cases in the United States per year, and that's really not very meaningful to any of us in this room. When you're affected, it's 100% of you have the problem. But in there is carcinoid, the most common. 55% of all the neuroendocrine tumors, as we learned, come from the intestinal tract, and of which the terminal ileum, the lower part of the small bowel, the distal part of the small bowel, is the primary source for the most common carcinoid in the intestinal tract. And that has to do with the cells that we heard about this morning from Dr. Asa, namely the enterochromaffin cells. And because they're in that area of the intestine and they have special properties of stain, like serotonin and substance P, another peptide, as a marker, by the by, it's known as the carcinoid or neuroendocrine tumor of the small bowel. And we heard about other tumors that are listed here: medullary thyroid cancer, which is a neuroendocrine tumor of the cell in the thyroid, and the pancreatic tumors, which we also heard about, that predominantly secrete one hormone and are named according to the predominant neuropeptide that they're making. So if it's a glucagon-secreting tumor, it's a glucagonoma. If it's a gastrin-secreting tumor, it's a gastrinoma, insulin, insulinoma, etc. And as we also heard this morning, 40% or 60% are non-functional of the pancreatic neuroendocrine tumors. About 40 to 45% are functional. In terms of carcinoid tumors, we know the definition. We've heard that. And what are the nature of the neuroendocrine tumors? Just to bring it back again, they're all derived usually from Crest origin. In the embryonic state, they migrate to different places. They arise predominantly, as we've heard this morning, from the gastrointestinal system and the pancreas. And the carcinoids themselves, 29% or so, arise from the lung. But the point is they're episodic in their secretion. That means they're not autonomous. That means that they are under control. And what makes them under control is the property that all neuroendocrine cells have, and that is they have receptors, I call them locks, for the keys. And the key in our body is somatostatin, and industry has given us a look-alike key, a powerful key, a synthetic key called Octreotide, or again lanreotide. There's identical class and almost identical in terms of potency. They predilate to the liver, and I'll show you the only picture I have in my imagination as to why they, as we heard, they predominantly go to the liver, that is the tumors of the pancreas and the small intestine. And again, you'll see the word SST2. It's somatostatin receptor subtype 2. This receptor is a very important receptor in our body, and there happens to be 5 receptors for the same key, somatostatin. That's the redundancy and the importance of that hormone in our body, because it serves as the pituitary for the neuroendocrine system. So it's a circulating phenomenon that regulates the cells that aren't regulated by the pituitary, alluded to by Dr. Ezet. And this is my Matuse. And that's the drawing. It's almost like a Matuse drawing, I think. But what it shows is very, very simple, and that is the predominant tumor of the intestinal tract is the ileal area, and of course the pancreatic tumors. Now you'll see a red vessel going to the liver. That's a unique vein. Okay, you know arteries take oxygen to the tissue by definition. This is actually an artery to the liver. It's called a vein. But as a vein, it functions to receive things from where it came. In this case, the neuroendocrine cells shed into that vessel that returns as an artery to the liver. So it's supplying the liver its blood supply at the same time to the liver to detoxify. And that's why so rapidly I think the liver is involved. 70% of all the ileal tumors that are found at surgery have metastasized to the liver by the time they're found. Again, that's 7-8 month gestation, way after the fact. And the early detection becomes critical. And we'll hear that today from Dr. Baum as we go forward in diagnosis. The pancreas is the same way. The pancreas tumor cells leave the pancreas and go into that vein, which carries forward to the liver almost instantaneously. And that's why there are seeds in the liver almost at the same time that the tumor starts to grow in the respective organs. This is just a repeat of all of the neuroendocrine tumors, and we've heard about the rising observation. The incidence has increased in the United States since 1989. The SEER data clearly shows that there are more new cases per year. It's been alluded to that there's more earlier identification or more awareness of it, and that may be true. But the prevalence is about now, we know fairly well in the adults, the prevalence is about 110 to 120,000. That means at any given time in the United States, we have 120,000 people suffering neuroendocrine tumors. And then it goes down from there into the pancreas for the other tumors you've heard about. Now, this is a slide you saw earlier as well. This is a masterful slide by Wick in 1984. I think he looked and was looking at Godwin's original data from the National Cancer Institute. Suffice it to say that as you see the arrow go, that's the natural course of carcinoid. So at some time, at time 0, it starts to grow, and at about 9.5 years, there becomes metastasis to the liver in the classic cases, and with the metastasis comes the persistent flushing, the persistent diarrhea. I think nocturnal perspiration and fatigue are the two other very important points, and that affects and impacts quality of life as well as the flushing that we heard about earlier. And this is just a picture, a very sophisticated picture of the lock on the cell. So as you look down, you're looking in through the cell directly into it, and all you have to do is visualize octreotide or lanreotide or our God-given somatostatin locking into a specific receptor. In the case of octreotide and lanreotide and valproatide, they're all the same class drug. They lock in preferentially to receptor 2. And these cells are replete with receptor subtype 2, and that's why we can exploit them. We are learning more and more about the actual receptor expression, and we now know there are differences in the actual quantity of the receptors on that ileal tumor versus the pancreatic tumors. And it's amazing that even though the expression is relatively small, that it's been able to be carried into the clinical arena for therapy. And this is the biology. We heard about the specific stains, and these tumors are totipotential. Depending on where they are, they tend to make a particular peptide. They can make more than one peptide, neuropeptide. In addition, they often make an amine like serotonin in the case of carcinoid, histamine in the case of the carcinoids of the stomach, catecholamines, adrenaline in the case of tumors of the adrenal gland. Again, this is the biology of it, and I have to nod to Enrico Solcia, and we heard the reference to the 2000 WHO classification. Enrico is from Pavia, and he headed up a team of pathologists in 2002 to put a definitive classification of the carcinoid tumors. And there's also a classification, as we heard this morning, of neuroendocrine tumors of the pancreas. But in general, the most commonly encountered types of tumors, and this is where this slow-growing nature comes in, are the number 1 and 2 for you to read. And they're described now pretty well as well-differentiated endocrine tumor or well-differentiated endocrine carcinoma. And one is termed typical carcinoid number 1, the atypical carcinoid, referring oftentimes to the tumors, carcinoids of the lung, are atypical, and they have a more infiltrating type of property that Dr. Asa pointed up earlier. I think we are seeing a larger group of small cells, particularly in the reproductive system. I think there are more, we're encountering several neuroendocrine tumors, small cell variety of the cervix and the ovary. And then there's the mix, and as you go higher classification, the 3 and 4 classification are more aggressive. They lose their property of sameness, of the commonness. And this is a well-differentiated kind of tumor. It's called, Dr. Wick classifies them as 1, 2, and 3, and these are using Wick classifications. And as you can see, there's a salt and pepper type of pattern just to show what was already described. And this picture is the chromogranin staining, as Dr. Asa showed you, which imparts the essence. I mean, morphology is important. It has been for years, but as was pointed up earlier, carcinoid tumor was just a term. And now we know that there are very definite staining characteristics that impart the essence, and perhaps the differentiation of these cells as being neuroendocrine cells. Ki-67 was mentioned, and I'll just brushstroke this to say that even though it is crude, it has become the standard in the European classification for the proliferation index. At our university, we use the MIB1, which is just an antibody to a different part of the Ki-67 molecule, and it happens to be a bit more specific. And this is to show you when their Ki-67 is heavily stained, many of our people come in and they say, what's my Ki-67? Or my Ki-67 is this, this, or this, and they're very beat down. And of course, it's crude, but people affected by neuroendocrine tumors feel that it's almost a bad thing for them, and they come in, and again, this just shows you an arrow of the cells, the nucleus, those cells that are proliferating, and you can see there are many of them, and that's a high Ki-67. Now, what I'd like to share with you about Ki-67 is that a lot of times the biopsy, and this was also alluded to by Dr. Asa, you have a core biopsy, And think of it like a piece of sausage. It's not homogeneous, it's not consistent, it's heterogeneous, and if you cut it on one end, you have one type of Ki67. However, oftentimes we get the core and we're cutting on the other end. And so the Ki67 may not be the accurate reflection, as Dr. Asa alluded to. So you have to put it in perspective. I know when it's part of you, it's critical, but you can't always have the same answer, even with different cuts on the same piece of tissue. And so it is crude in that respect. But it can be generally helpful, but we're moving on to different markers now and different predictors of how a tumor is going to progress. This is just to show you serotonin isn't in every one of the neuroendocrine tumors. It's heavy in the midgut tumors, and that's why it serves as a good sensitive marker relative. It varies if someone excites you or you exercise or you're emotional, you can jump your serotonin by 100, 200 nanograms oftentimes, and it's very transient as it breaks down. But for the midguts, it's helpful to see and to correlate with symptoms of flushing. But serotonin doesn't exist in all of the tumors in the same concentration. For instance, in the foregut, it's not as high, and in rectal carcinoids, it's almost non-existent. We heard about 5-HIA. I'll make one point about the 24-hour urine for 5-HIA. It's worthless unless you have about 20 to 25% known tumor burden in your liver. So to come in and draw a 24-hour urine on a person that you're working up a diagnosis for and the CT can't find it, the 5-HIA is meaningless. And something like Prozac or Zoloft or some of those serotonin meds can raise your 5-HIA by 5 to 10 milligrams per 24 hours. So we rarely use it until we need it as a marker of treatment and therapy. This is the point. This is the one test that I think is very helpful. I was hoping it would tell me tumor burden, but pancreastatin is a breakdown product of chromogranin A. And if you think of it like I do, I think of chromogranin A kind of like a big earth person pre-hormone. And it's doing nothing until it's broken down by another enzyme, and it's cleaved to this peptide called pancreastatin. Now, pancreastatin is very, very sensitive, and it's measured in very small amounts in the blood, as are most of the neuropeptides. Picograms per mil. That means 10 to the minus 12th. It's 100 times more sensitive mole to mole than chromogranin A. And what we have found out and what we have just submitted says very clearly that pancreastatin is an excellent marker for liver metastasis and progression in the liver. And yes, the ground shakes when pancreastatin rises by 1,000 picograms per mil, and you may not see the changes for at least 2 or 3 months by regular CT or MR. So yes, and there is one lab in the United States doing pancreastatin reliably. We set it up at Ohio State, but the one at Inner Science Institute is the one that most of the big labs like Quest and ARUP send to. And there's also a great one in Europe. Ardell has a very good pancreastatin assay, but it's very, very, very good for liver metastasis. These are the congeners we've been hearing about. There's somatostatin on the top, octreotide modified. It has one amino acid difference. And on the right is lanreotide, which is in Canada, and it's coming in the United States for neuroendocrine tumors as not inferior. It's been approved for growth hormone secreting tumors in the United States. And it has properties as well that are appealing. It gives you a nice steady state level versus octreotide, which gives you a peak and trough in its depot form, long-acting repeatable. But as you can see, they're very, very closely. They look an awful lot alike, and specifically they look a lot like what God made, and that is the somatostatin itself, the native. And the genius of the synthesis is that they cut it down to 8 amino acids, to 8 proteins. And this is the mechanism that we've been hearing about, and we'll learn much, much more about with Dr. Baum's talk, and that is the principle. The tumor cell on your left, or the normal cell on your left, has the keys on it, has the locks on it, those little Y's on there. And the key fits into the lock. But you cannot remember or forget, you cannot forget that the target cell that we also heard about today also has locks for somatostatin on it. So when you use octreotide, and we're hearing more and more about its therapy, we'll hear that from Dr. Arnold shortly, but it has also therapeutic actions, but it has palliative actions as well. And that is, it protects the normal cell from getting hit by the tumor hormone. Now to the schemas. And they're all on there, and they're in order, and I'm just going to make a comment or two as we go forward, and the details will be filled in as we go along, hearing more of the therapeutic interventions. I look, and this is exactly what our people see when they come to the clinic for the first time. They register. That thing called INED is a Iowa Neuroendocrine Database. They give us permission to de-identify and to put their names on a registry. By that signature, it also gives me permission to tell them about therapeutic options that may not be actually IRB approved as yet, but are coming, because the protocol is a university approved protocol. As such, you can see how we do. The Octreoscan is everything at the very beginning, and the somatostatin congeners are used almost immediately for several indications. And what we can say, or what I can say, is that somatostatin congeners are therapeutic as well as palliative. And the other observation we've made is if you give enough somatostatin congener to stop the symptoms, you've given more than enough to block and to occupy the tumor itself. And that is because there are more receptors on the tumor, more locks on the tumor than there are on normal tissue. As such, if you get the symptoms blocked, then you are giving enough to saturate the tumor. They're anti-proliferative, as we know. If they're Octreoscan positive, it's wonderful, because that means that the octreotide or lanreotide will work definitively to be anti-proliferative. It's palliative as an antagonist of the tumor hormones, as I said. It blocks serotonin's action at the target cell and probably helps to inhibit its secretion at the tumor, in the ileal tumors. And we're going to learn from Dr. Arnold just how powerful a therapeutic agent it is shortly. In terms of the other therapeutic options, there are the options on that graph that you all have, the schema. I look at things as cidal or static. Things that kill the tumor that are cidal is obviously surgery. You're removing the beast. Hepatic embolization or Y90 spheres, so either using talc. Hepatic chemoembolization, I think, carries some risk, but the bland embolizations many of you may have had already, and the Y90 spheres or yttrium-90 with either glass or bio-non-degradable beads that go right into the terminal vessel, innervating the tumor and kills. That's cidal therapy. That is definitive therapy. And of course, chemotherapy can be cidal as well. Static therapy must needs be considered to be the somatostatin congeners. It stabilizes, it helps you maintain a chronic problem, and it should be used forever as far as I'm concerned. And the anti-angiogenic drugs, which are coming out now. And there are several excellent ones that are being trialed for neuroendocrine tumors of the pancreas, as well as the neuroendocrine tumors of the small bowel, and those are static drugs. They choke, they inhibit this new vessel growth of the tumor to the tumor, and as such they stabilize the tumor, and you can get partial response. This is old data just to show you that the symptoms and for which the indication in the United States in 1999 was for the symptom control of diarrhea due to carcinoid and vasoactive intestinal peptide vipomas that Dr. Azad alluded to. But you can see you get 100% inhibition or stopping of the diarrhea, and almost 100% of the flushing as well. And that's the symptomatic relief. And that's how the indication came out in the United States. Oops, I'm sorry. Speaking of the surgery box, just a comment. Although there are few studies available, all the studies show benefits with either primary tumor removal or tumor debulking for neuroendocrine tumors. This is not a situation, and that's where the medical oncology field, when they saw these tumors in the ileum and in the liver, they said, let's just do chemotherapy. And for several years, we went through a situation where the tumors were still in the small bowel or still in the pancreas, and chemotherapy does not work in most of the stages of neuroendocrine tumors. We now know that if you remove even primary tumors when you can find them, or you debulk them, and I am talking about Pommier's papers from Oregon. We're talking about Phil Bouchard from LSU. There's an excellent German paper recently talking about the same effects of debulking or removing primary tumor. The only caveat, sadly, is that if the tumor burden in the pancreas is too great, that's a disincentive for even the best surgeons to do. And we use Doppler ultrasound to try to estimate tumor burden. And it's a very difficult thing to do non-invasively, but a Doppler ultrasound is excellent of the liver. It hears the blood flow versus the liver blood flow. That's what a Doppler does. It sounds out the enhanced blood flow to the tumor and gives you an idea. And so that's a very helpful thing to try and get an assessment. And although it shows many tumors on the liver, you'll be very surprised that the actual tumor burden is much, much less than you would have predicted by just saying liver full of tumor means nothing. So you need to try and get a quantitation as best you can so that that helps you in your option of what your next decision should be. A comment only about hepatic arterial chemoembolization. You must do the Doppler ultrasound, as I say. Less than 60% is generally safe to do the procedure. We use pancreastatin levels. If they're greater than 3,000 picograms per mil, it means that there's too much tumor burden, and if you try to do local ablative therapy, you can hurt the liver. We've had several instances where the cirrhosis was created by the treatment. And so you want to be very careful, and when I speak to you, I'm speaking like you're speaking back to me because you're in charge of the decision track. And that's why a multidisciplinary group that we've heard about that's excellent in Canada and Germany and around the United States, 7 centers, are important because you have talking heads of expertise that come together. But each of these has a downside. You always pay something when you have them done. It's an issue of risk versus benefit. And these are just a generalization about the effectiveness. It's a good option. Don't forget, these are good options if they're appropriate. Clinical trials, the anti-angiogenics, again, just a word or two. The everolimus drug, RAD-001, from Novartis is being developed. I think there'll be indication in about 2 years. Sutent sorafenib is another anti-angiogenic that may get early indication for pancreatic neuroendocrine tumors, and they're excellent. Pancreastatin is another very good peptide because every time I talk about an intervention, you should measure pancreastatin if there are liver lesions. Because a 20% decrease after therapy bodes well for stabilization for periods of time. We know that now. We know the data of our DIL. Our own studies show that a 20% diminution following embolization of pancreastatin or the treatment with sandostatin bodes well for stabilization of the tumor. So pancreastatin is an excellent marker for therapeutic evaluation. Finally, the systemic peptide ablation that we've heard about and we're going to hear much more about from Dr. Baum is the arrow that we're striving for in the United States. it's in my dreams that it'll be a solid arrow, that we would have surgery, just like you treat thyroid cancer. You would have surgery, and then you would take I-131 ablation of the rest of the thyroid, and that would be the biggest treatment combination. That's my dream for neuroendocrine tumors as well, is that we could do definitive surgery with early detection and then just treat empirically with Y90 or lutetium and be done with it. The Octreotide scan, if it's possible, the patient is eligible for somatostatin congeners, the tumor growth with symptoms, tumor growth without symptoms, stable tumor with symptoms. Those would be indications for the congeners in ours. And that's an Octreotide scan on the left side. This patient came in with a very positive PET and a very positive Octreotide scan, underwent systemic radioablation, and then came back promptly and had chemotherapy and is doing well 3 years from the time of the diagnosis. This is the congener that is called was called Octreotide. In the United States, it will be called Onalta. It's called Dotatoc, Y90 Dotatoc. And there's Y90 dotatate, and that means just a slight modification of the octreotide. But this is the systemic agent that we're going to hear more about. The principle is very similar. You put it in the vein, you go to a cell in the middle, which is replete with somatostatin LOX receptors. It attaches, it's taken into the cell, and then it explodes away from the cell, which is the source. And it does damage in all directions away from itself. So that's the principle of Y90. It has a range, we'll hear shortly, of 9 millimeters. Lutetium has a shorter range, and that is what you hope for with the systemic radioablation. But understand the expression of these receptors are low. I mean, you don't, that is, how many receptors are there to take the keys, and yet it has a clinical significance. I think it's just remarkable. And finally, the study that we just finished, the North American study using Octreotide, has been submitted. It was 90 patients using the Y90 in several centers in Europe and the United States. Excuse me. And the data on this is just to show you that the pancreatic tumors give you a partial response. We didn't have many of these. We had a total of 38 patients as part of the whole study, but the pancreatic tumors responded very, very well to the Y90 therapy, giving us partial response in 60%, and stabilization of the neuroendocrine tumors of the bowel in 68%. Our results are identical to the rest of the European data. They were made objectively stable, or we had for long periods of time, and you can read that. The conclusion was 75% of the patients had objective response or stabilization of disease with treatment. There's one very important point just to share with you, that you don't get upset when sometimes tumors show by CT scan after a very aggressive treatment. And that was a study by Oberg in Uppsala several years ago with their pathology group. They biopsied a tumor, treated them with interferon, and then biopsied the same tumor. And the tumor didn't change very much, but the carcinoid part of it went away. In other words, the tumor replaces themselves with fibrovascular bundles. So CT and MR are very unhelpful in terms of telling you what the state of that tumor is. Clearly functional scanning, such as we're going to hear about in terms of PET scanning, certainly in terms of gallium-68, will be most helpful, because that's functionality of the tumor versus the CT and the MR, which persist as our gold standards to decide intervention. But don't be dismayed when the tumors sometimes just don't go away. They're gone away, but they're replaced with something that looks like the same tumor. So I hope this is helpful. These are all options. As you go forward and you work back and forth with a center, you decide which ones are best for you, and they're not one way or another way. Most of them are reversible, so that you can keep changing and going back to even debulking surgery after several other options are used. Thank you very much for the opportunity. Peace.
Thank you, Dr. DeRizio, for an excellent talk.